Good afternoon, guys. All right, my name is Nikolai. I'm one of the instructors at LaGuardia Community College, right? Hopefully you guys can see, right? So we're going to start the OB with basic patient assessment and normal vaginal delivery. And after we do that, we're going to go through the abnormal, right? The abnormal presentations. So when we are going to arrive for these calls, we're going to start them as your regular patient assessment, right? So when we come in, we start with a seat size up, right? We say, right, BSI scene safe, but don't just say BSI scene safe. If you're going to go for an OB call, someone who potentially is going to give birth, tell me what some of the protective gear you're going to need.
Gloves.
Gloves, what else?
Goggles.
Goggles, what else? Gallons, right, very important. Sheets, an OB kit, right? Because you don't know possible diseases this person may have. They may have hepatitis, they may have HIV, in addition to, right, other things. In addition to, when you're delivering, all the contents coming in. Meconium fluid, blood, feces, everything in your face, right, as you're standing here. So you want to have gown, eyes protection, face protection, everything, right? Everything you got. All right, good. So you're going to tell me that you get your BSI on. We make sure our scene is safe. And very important, who do you want to call before you commence with any deliveries so that they're, who? ALS, right? You want to call paramedics so that they already start to come to the call the moment you see that you arrive to the scene, you see a patient, right? And you want to request ALS. All right. You also, what else in scene size up? What else were you considering?
C-spine.
Right. Possible trauma, right? We're going to say there's no trauma, right? There's also a number of patients, right? So we have one patient here, and it's a nature of illness. We're going to say it's obstetrical complications or maybe not complications, right? No, normal delivery, right? So that's our scene size up. We come to the scene and we're going to make our general impression. So general impression is, I know you guys usually repeat back what the instructor told you, right? But what you want to say is what you see. So I'm going to just pick randomly. Let's say I pick you, right? If you were to come in, and let's pretend this was a clinic, right? And a clinic, and they called you because somebody was having active contractions. You come inside and you see this, right? You walk inside this room. What would you tell me? What would you see?
I see a 40-year-old female, like, supine on the bed
Okay, is that all?
with her legs up,
Okay, and there's something very specific about this female,
and she's pregnant.
and she's pregnant, right?
40-year-old.
Right, very good. I remember I did it in the same class, but the other group, and they said she has a very big belly, right? So yeah, that's fine, right? But you definitely see, right, that she has a gravid uterus. That's what we call it, right? Gravid uterus. So if you walk inside, right, you definitely see, right, somebody laying down, right? They have a gravid uterus. What you're thinking about, what's going to happen? Maybe they're going to deliver, maybe not. Maybe there's a complication, right? But at least you have a rough idea that what you're walking into, right? So you're going to state your general impression, what you see. Then I have to get their mental status. It's very important to assess it initially to know if they're a good historian, what they're telling me is correct, meaning they're able to make decisions, right? And I want to know if they have good perfusion to the brain. So how would I get their mental status? Who could tell me that?
You ask some questions.
Which questions would you like to ask them?
What's your name?
Good. So excellent, right? So before you get to that, what is your name?
Stephanie.
Stephanie? So you'll say, hi, my name is Stephanie, I'm an EMT, right? I'm here to help you. What is your name? And then she'll say, okay, my name is Mary. Say, Mary, can you please tell me where you are? She'll say, okay, I'm in the clinic. And another good one is, please tell me the year, right? Don't ask them daytime or what date is it. I may not remember myself. I work night shifts, day shifts, I don't know. If I don't see the windows, I don't know, it's day or nighttime. But if you ask me what year, I'll tell you 2022, right? So now she is alert to self, right? To location and the time, right? And then we're going to ask him their chief complaint, essentially why we're here. And you could ask him, what is the reason you called us, right? Or maybe she didn't call you, maybe one of the nurses there or her, husband, boyfriend, whoever called, right? What is the reason you called us, right? So I'll say, you know what? She's having active labor. She has an urge to push, right? Her water broke. So if they tell you anything along those lines, right? What are you anticipating?
Birth.
Imminent birth, right? So as you woke up here, the first thing you want to say, right? Do you have an urge to push? And you want to say, do you mind if I inspect, right? I just want to make sure. And we want to see, right, if there's crowning, right? Why? Because if there's crowning and she has an urge to push, the baby's coming out immediately. And we want to make sure, right, we support the head. If this were to occur, we'll support the head so it's not explosive delivery. And more importantly, right, I don't want to tear the perineum. I don't want any trauma to the mom, right? So let's say I look, there's no crowning, right? Let's say the water broke and she is having contractions. How often should the contractions be to know that the labor has begun?
When it's minutes?
How long?
Between 1 and 2 minutes.
Yeah, so roughly speaking, 3 to 5 minutes. 3 to 5 minutes when they are that apart, you know the labor is already commenced, right? And since we're on this topic, what is, labor usually has 3 stages, right? I don't know if you learned about that. 3 stages of labor. What is the first stage of labor? Or how do you know the first stage of labor has?
Water breaks?
Hmm?
Water breaks?
Not necessarily. How do you know you at the first stage of labor? So right, there's something called dilation, right, and effacement. So the first stage of labor is usually the contractions are roughly 2 to 5 minutes apart, right? And the end stage of it, right, it's usually you have cervical dilation of 10 centimeters. Do you know how they check that in the hospital? They take sterile gloves and they put it in the vagina, and then the doctors will measure the distance, right? So dilation means how far apart, and effacement, how thin the cervix is, right? So dilation and effacement. And usually the first stage of labor is divided into like latent stage, that's the first part, up until 6 centimeters. It's for nulliparous, or like the first time that women are pregnant. 0 to 6 centimeters, do you know how long it roughly takes? How many hours? First pregnancy, until they get 6 centimeters dilated.
Is it 12 hours?
20 hours.
20 hours.
And if it's a subsequent second or third, that will be like 14 hours, roughly speaking, right? So the first one, maybe 20 hours, right? So if they're not up until 6 centimeters, you may be there for a while, right? And then the active phase is after 6 centimeters. It's relatively quick, right? It's much faster than that, right? And when they're 10 centimeters dilated, right, that's the end of the labor stage 1. Then you have second stage of labor. That's from dilation of 10 centimeters to the fetus delivered, right? So second stage begins with 10 centimeter dilation, ends with fetus delivery, and then the third stage of labor starts with fetus delivered and ends with placental delivery, right? You guys know how long it roughly takes for placenta to be delivered?
It could take a while,
A while. To give you a rough number.
like 15 to 30 minutes.
Yeah, about 5 to 30 minutes. 5 to 30 minutes. So are we going to stay and wait if, let's say, we're in an ambulance for the placenta to deliver? No, we're going to initiate transport, right? We're going to obviously inspect, we'll go through all that, right? But those are the 3 stages of labor, right? So we made sure she has good mental status, which that's why we're here. She said we have contractions, right? And now I want to make sure right, we're going to go through ABCs, right? We check those, no crowning, right? So we're okay with that. Airway, breathing, circulation. So you could say she's talking to me, right? She told me her name. She's able to make sounds. She's able to phonate, right? If you really wanted to make sure, you could ask her to swallow. She clear secretion. So you'd say, my airway is clear and patent, right? Then we check our breathing. How do we check breathing?
Full chest raise.
We look at the chest rise, right? What else we can do? Auscultate long sounds, right? Bilateral long sounds. We could look at work of breathing, and then we could put something on her. I don't know if you guys can see, but we could put this guy here. What is this? Pulse oximeter, right? So let's say we look at her vital signs, and we see pulse ox is 96%. Is this good or bad?
Good.
Right. So what's a normal pulse ox?
94 to 99.
Yeah. So 95 to 100, 94 to 100, right? Good. If it was below that, you would consider giving them what? If it was like 90%, let's say.
NOD.
Not a breather or nasal canal, right? You want to support them with some supplemental oxygen. So that's breathing, right? And a good way to assess that, if you remember mnemonics, right? Dr. Q, depth, rate, quality. So depth, how deep I'm taking the breaths in, right? How fast, the rate, and quality. Am I using accessory muscles, right? So we've done that. Then we do circulation. How do we check circulation?
Heart rate. Blood
Right.
pressure.
So I will check her radial pulse, right? I will see, right, she has good radial pulses. I'll look at her color temperature condition. Let's say she is warm. She's a diaphoretic, right? She's sweating. She's pink. What else? We got pulse. We got skin.
Any major bleeding?
Yeah, we're gonna say we checked, right? We don't see any major bleeding. We're gonna say her water did break, right? But I don't see any active bleeding right now, right? Is my circulation done? Right? Yes.
Yes.
We make our decision. Decision doesn't mean you're actually leaving the scene. My decision is a high priority patient, right? I definitely want to have ALS. If you haven't called them, you want to call ALS so they're arriving, right? If the contractions are imminent and she has the urge to push, I'm going to deliver it at that location. If not, then I'm going to move them to my ambulance. Ambulance is like my office. I have everything there that I need, right? So I like to do that there. So, but if they say I'm having active contractions, I have the urge to push, I'm not going to, start moving her. I don't want the delivery to happen midway through, right? So let's say we get inside the ambulance, and now we are, let's say we're doing our secondary assessment, right? Secondary assessment. Tell me some of the components of the secondary assessment. any component of the secondary assessment.
Would it be like sample?
Sample history, excellent, right? So, signs and symptoms, in addition to, right, you told me you have the urge to push, do you feel nauseous, do you feel like you want to vomit, anything else going on, difficulty breathing, so you ask her. Any allergies she has, right? Any medicine she's prescribed, very important, right? You want to see if she had any problems developed during pregnancy and they prescribed her medicines. You want to also know if she's on prenatal vitamins, right? Past medical history before pregnancy and then after, right? Maybe she has gestational diabetes, right? Or gestational hypertension, right? Secondary to the pregnancy. Ask her if she's getting prenatal care, which doctor she's seeing, right? Did they tell her if there are any complications with that, right? Past medical history. Last thing, she had eat or drink, right? What were you doing, right? When this occurred, she probably told you I came to the clinic for a checkup or something along those lines. Simple, excellent, right? What else? Secondary assessment. OPQRST, I'm glad you said that, right? So let's say she has no pain, right? Because OPQRST is usually for cardiorespiratory or isolated pain. So if I have no pain, then you're going to say, well, tell me, where's your pain? I have no pain. On 0 to 10, how bad is the pain? I have no pain. Show me where the pain travels to. I have no pain, right? Do you think those are appropriate questions to be asking her? No. Right, so over here on the left-hand side, right, I wrote some of the questions, right? So what do you see? What is the first one? Right, oh, yeah, after that? Are you pregnant? Very good, right? Yes, I am, right? What else you want to know? How long, right? What's the normal gestation? How long? Oh, and then weeks, 1 year. You want to carry somebody for a year?
40 weeks?
36, right? Roughly speaking, 36. Yeah, sometimes you can go for a little bit longer, right? 36 weeks, right? If they say, I'm not sure, you could ask them, what was your last menstrual period, right? Let's say, you say, are you pregnant? I'm not sure. When was your last menstrual period, right? What else do we have there? Contractions, right? So how do I know that the birth is imminent? Contractions are how far apart? 3 to 5, or even more intense, right? You know, the best way to do this, you say, maybe she has a watch on her hand, and maybe there's a husband there, a boyfriend, say, listen, I want you to look at your watch, tell me every time you feel the contractions, and tell me how long they last. Right, so you have them like occupied, you have them being busy, right? So they're looking at the watch like, yeah, it's coming right now, right? So they'll say, okay, maybe it's now every 2 minutes, and it's lasting 20, 30, whatever the time frame, and it becomes more intense, right? So you know possibility of delivery is high, right? What else we have there?
Discharge?
Right, discharge, bleeding. So if the water broke, if bleeding, I'm very concerned, right? I don't want any bleeding. What else? Right. So yeah, we wanna observe that. So now let's say we assessed all this, right? And then what else is part of the secondary assessment? It's a critical criteria, by the way. If you don't do it, vital signs is there. Excellent. So we'll do full set of vital signs. Let's say my partner did them. I have them on the screen. If you guys can see it, heart rate is 111, pulse ox 96, bleed P 117/77, right? Temperature is 97, respiratory rate is 12, and tidal CO2 is 35, right? So vital signs are good, right? Something else, part of the secondary assessment. Focused physical exam, right? So on OB, what are you gonna check? So good thing, right? You check the belly, right? The fundus, right? The gravid uterus. You want to see if there's crowning. You want to see if there's bleeding. You want to see if there's any discharge, right? Like we talked about. So you want to inspect, right? The genitalia. You want to inspect the belly, right? You want to look also, right? In cases where someone who you suspect having high blood pressure or preeclampsia, you may see, right, edema formation, right? They may complain about headaches. They may complain about photophobia, things like that. So you will see some signs of that nature. Right, and so we've done our inspection. Let's say she says, I have an urge to push, right? And I look and, right, I may or may not see crowning. What do I want to start doing right away? She says, I have an urge to push. Come. Don't be embarrassed. What are you going to do?
She can do it. No, go ahead.
All right.
Okay, set the OB kit.
Excellent, right? So we unfortunately we didn't have like a full complete OB kits. So I brought some stuff here. I'll show you, right? So it's like incomplete. So what you want to do is I'll show you what's very important. You see how they have these chalks underneath her butt, right? You guys see that, right? And what I'm going to do is out of the OB kit, I'm not going to put one. I'm going to put several. I'm going to put like 2, 3 underneath her butt. I'm going to ask her to lift up her butt. I'm going to slide 2 or 3 underneath them. Do you know why that's for?
How
Not that they go through.
To keep things sterile?
Excellent, right? Excellent, very good. You know why? Because as the head starts to emerge, what else is coming out?
Feces?
Feces, right? Any meconium fluid, right? Anything else, right? Blood, if there's blood. And as they're coming out, they're piling out here and they're splattering you. So as the baby's head is emerging, I will fold one layer underneath her butt with all that stuff so that the other layer, right, is now still clean so the baby's head doesn't go plop in the feces, right? You follow what I'm saying? So you put this on, right? If I was in the ambulance and this was occurring, I would turn up the heat, right? You want it to be hot, like outside hot, like 90 degrees plus, right? Why? Because you want it to be cold. For the baby, you want it to be hot. That's why they put them right in the incubators. So turn up the heat in the ambulance. You get sheets, blankets ready, right? So I have some sheets. These are not per se sterile in OB kits. They're not really sterile in OB kits either, but they'll be smaller for the baby, right? They'll have a foil for the baby, and they're very important to have a head covering, right? What's the head covering for? Why is it very important? The head covering.
To keep the baby warm?
Yeah, and why is that very important?
Because they lose heat fast.
Excellent, right? The head is very big when the infant is born. You want to cover the head, and all the sheets, we're going to dry them, we're going to stimulate them. There's also in the OB kit, there's a bulb syringe, right? And how it works is you first depress it, right? And then if you need to suction, then you introduce it to the mouth and nostrils, and then you let it go, and then it will fill back up. Then you clear it in between, push it down, put it in the mouth, will pull up the secretions if need be, right? If the baby is vigorous, you're not going to use them, right? All right, so this is one of them. And then the other thing, they told us not to cut the cord because this mannequins is very expensive, but you're also going to have clamps, and you have either shears, special shears, or a scalpel, right? As the cord emerges about 1 minute in, we're going to do the following. We're going to, about 8 to 10 inches, you're going to put clamp, and then another 3 inches, you put a second clamp towards the mom. And then we're going to cut in between the cord, right, to separate the fetus from the placenta, right? Very important, when the fetus comes out, you don't want to elevate it too high up from the abdomen of the mom because the blood will flow back to the placenta. You want to keep it on the level, right, of the mom before you cut it. But once you cut it, right, we are going to give it to the mom. Why is it important? After you cut it, you stimulate, the baby's crying, baby's vigorous, right? We dry it, and then we give it to the mom, possibly to nurse. Why is that very important? Skin to skin, right? So warmth, skin to skin is very good. It's warm, right? It's much warmer than any blanket that you're going to do. So skin to skin, then cover with the blankets and put a foil on top of it with a head covering. And why is it important to give them to the nurse if they're going to nurse?
There are hormones in the mother's lactation.
Okay, which hormones?
There is, what is it called? The love hormone?
The love hormone, right? So oxytocin, right? Oxytocin is being released, but it's more importantly, you know why we want it? It's not, bonding is good, but more importantly, oxytocin causes uterine contractions. So if there's bleeding or if the placenta is not emerging, the oxytocin release is going to contract the uterine walls for the emergence of the placenta, and also this bleeding is going to vasoconstrict, right? Sometimes if there's active bleeding, we do a fundal massage, right? To make sure the uterus is not boggy, right? Because they could bleed a lot post delivery, right? So those are some of the things. So we draped everything up, right? I got all my chucks underneath her butt, right? If you're gonna send your partner, right? If let's say there's no husband, no boyfriend there, and she says, I want someone to be near me, can you hold my hand, right? Never give her the hand. Never give them the hand. Why? They'll break it. They'll break it. Always give them 2 fingers. I learned from experience, right? They may be small, 100 pounds. They will tear your arms off, right? So always give them 2 fingers, right? I'm right here, right? But be very cognizant because when they push, and we're going to tell them, right? 1, 2, 3, push. Your hand is gone. It's going to be obliterated, right? So make sure you give 2 fingers, right? So everything is set up, right? Rich is going to go ahead, right? He's going to be my partner. So let's say we set everything up. Right, we got everything draped, turn up the heat, right, get this up. And the other thing I want to say, I want to get my resuscitation equipment ready. So I got my bulb syringe, I got my BVM, right? I'm going to show you this stuff, right, the meconium aspirator, and I have a sterile glove just in case there's complications. So I have everything laid out. I don't wait until there's problems to start opening stuff. I put everything next to me so I need it, right? So you can go ahead and initiate the press the button and then come back.
Sure.
Yeah. So Richard, what he's going to do is the controls for the simulator is in that room behind the windows, right? I know it's high tech stuff, right? He's gonna click the delivery, and as you're here, right, you want to make sure your hand is supporting, right? So there's no explosive delivery because this perineum can tear. You see what I'm saying? In the hospital, they do episiotomy, right? So you see how it's emerging? So you're guiding it. You see how it comes out, right? And then what I'm doing is I'm rotating and I'm guiding, right? I'm guiding it down so the shoulders are emerging. I check for the neck. There's no what around the neck?
Step off.
No. There's no
Cord?
There's no cord. There's no what? There's no cord. Because if there was a cord, what should I be doing?
Pushing it back.
No. If there's cord, I would try to unravel it, or if I had to, I would cut it, right? So as the baby is coming, you want to make sure you're guiding it, right? And at this point, it's going to come relatively quickly. And what Rich is going to do is going to get my sheet, right? So the baby comes out, and we see, right? Remember what I said? I don't want it to be high up. I want it to come here, so come over to my side. You want to make sure you hold it very tightly, because what's going to happen, you don't want it to fall, right? And then what we're going to do is we're going to dry and stimulate. You want to flick the soles. You want to rub the lower back. You want to clean the head. And then if I saw there was any secretions, do you mind passing me the bulb syringe, the blue one, right? What I would do is I would press, as I told you, right? Press here. Section the mouth, clear it, right? Right? And at this point, I'm constantly assessing the baby. I'm seeing the response. So let's say baby is vigorous, baby's crying, baby's not limp, baby's moving about, right? I do see some blue and red limbs. Is that bad or good?
You said blue and red?
Yeah, blue and like bluish, purplish color.
That's bad.
That's bad. So for the initial phase, that's fine, right? It's called acrocyanosis, right? And that's totally normal as long as the trunk and the head is good perfusion, right? So we stimulate, the baby is crying, right? All that. It's now been, let's say, a couple of seconds, maybe a minute, right? We see that there was good tone. There's no need to resuscitation. We clear the mouth. We said we're going to cut the cord. How much? 8. So we put the first clamp 8 to 10, and then we put the second clamp. You holding it, Rich? 3 inches towards the mom, right? And we're going to cut in between. Now, what happens if this side towards the baby is still bleeding from the end? What can we do? You put another clamp to reinforce it. What about if this side is bleeding? Not necessarily, because the placenta is going to come out. I'm not so concerned, right? The placenta is bleeding. You can reinforce it, but very important. If this side from the baby is bleeding, I want to definitely reinforce it, right? So what I'm gonna do now, because this placenta, we cannot cut it, so I'm gonna remove the placenta so Rich can go ahead and put it on the mom. But while I do that, I just want to explain to you. So when the placenta comes out, and we said it comes out about 5 to 30 minutes after the delivery, right? It's not gonna just come out like this. How do I know it's about to be delivered? What you're gonna see is this. First, you're gonna see a gush of blood. We call it the bloody show. And then the cord that was cut is going to lengthen. It's going to go like this, and you see a gush of blood. And then the fundus is going to become globular, right? So that tells me that the placenta is about to be delivered, to come out. Always take it with you, right? Why is it important to take it with you? So what else? Yeah, it is the patient's property. Yeah, so not per se test, but you know what we see? So this side is towards the mom, right? And this is towards the baby, right? And this side we call the shiny Schultz, and this is we call the dirty Duncan, right? Dirty Duncan, shiny Schultz. They're gonna look if there's chunks missing. Let's say chunks are missing. So where do you think the chunks are left? Inside the womb. So they're gonna get a procedure called dilation curettage. They're gonna scrape the inside of the cervix, right? Because if we don't, they're going to get a massive infection and sepsis, right? So what you're going to do is, when the placenta comes out, if you don't have no other containers, you're going to put it in a red bag and make sure, I'm going to say it 105 times, make sure you put her name on the red bag. Because the moment red bag is placed on the patient, on the bed or whatever, they think it's biohazard content, goes in the trash. You want to put her name, you want to write placenta, you want to make sure, right, all that is written there, right? So there's no ambiguity, right? So they're going to check for those reasons, right? If there's chunks missing, it's probably inside the, right, her uterus, somewhere there, right? And they got to scrape it down. So we're going to pretend we cut it. It's still, the placenta is still inside. We're going to go and say, Mom, you have a beautiful baby boy, right? And we're going to go ahead, put it skin to skin, right? So here, right, we're going to open the gown. And if the mom was playing to nurse, right, we ask you, are you playing to nurse? Are you gonna do formula? She says, okay, I'm gonna nurse. You're gonna place the baby, right, so she can hold it. And then what we're gonna do is, right, we're gonna wrap the baby around her with sheets. Make sure there's head covering, and then you're gonna put sterile, not sterile, foil wrap around it to preserve the heat. Make sure the heat is on. Now you have two patients, right? So what I would do is I would put a pulse ox on the baby right away, on the right arm, right away, or on the right leg. And you also want to be cognizant that the placenta is coming out, and then watching for hemorrhage. Very high chance of postpartum hemorrhage, right, when they deliver. So you want to make sure that, right, you're watching that. There will be PCOP on the mom in case, right, you need to acquire a vital signs. Hopefully the medics are coming, they're not too far away. And then why do I put a pulse ox on the baby? To see what?
Breathing?
Well, pulse ox tells me what? Pulse oximeter.
Perfusion.
Well, not per se perfusion. It tells me a couple of metrics. It tells me saturation of hemoglobin, and it tells me, right, the heart rate, right? So what did you suppose after 1 minute of delivery is the infant saturation?
Hopefully 100.
100? What do you guys think? 1 minute. 100? You could tell me a number. You could guess. Everybody's 100. 1 minute. Baby delivered. We cut the cord. Mom is nursing. We put a pulse ox. How much is saturation? How much?
60 to 65%.
Very good. I see somebody who's reading the board, right? Excellent, right? That's why I wrote it there, right? So the first minute is 60-65%, right? That's not abnormal. That's normal. Why? Because they have acrocyanosis. They have blue legs and limbs, right? So you're not going to see 100%. Look how long it takes to get to like 95%. Almost 10 minutes, right? So 10 minutes it takes to transition, right? The lungs getting oxygen, acrocyanosis being relieved. So it takes some time. So don't get alarmed 1 minute, 2 minutes in. It's at 60, right? Now, and I'm looking at the heart rate. Roughly, I want the heart rate to be above 100, like 160, 180, sometimes they're in 200s, right? Because if it's low numbers, we're going to have to resuscitate, right? You guys probably learned if the heart rate is less than 100, right? What are we going to do? Not CPR. First, we're going to stimulate, rub the lower back, and flick the soles and dry them up. Let's say we did that for 30 seconds, didn't work. Then we're going to go with positive pressure ventilation with the BVM, right? So that this is the BVM I got here, right? So we're going to do this. So first we stimulate. If that didn't work, we're going to do positive pressure ventilation. This is a manometer, right? Sometimes you may need to overcome a pressure. So here, this is a pop-up valve, right? That relieves the pressure. Sometimes for these patients, you may need to close it, engage this, right? To deliver the appropriate ventilation. So you only need to give just enough to get chest rise, right? If the heart rate is less than 60, you do what? CPR. And what's the ratio to compressions ventilations for a neonate?
3 to 1.
3 to 1. Excellent, right? So 3 compressions to 1 ventilation, right? When you're doing that, it's different from the pediatrics that you learn, right? So less than 100 after stimulation, right? Still dropping, positive pressure ventilation. Less than 60, you're going to do what? CPR, right? 3 to 1. Make sure the heat is on in the ambulance, right? The baby's not cold, you're still drying and all that. I'll show you what paramedics used to have, right, when we come in. This is called the meconium aspirator, right? In some places you may still see them performing it. If you know what's meconium? What's meconium? It's the baby first poop. They poop inside, and they aspirate. It goes in their lungs. Imagine you took your poop, and then it goes into your lungs. You take a breath in when you're about to come out, because everything is floating, right, in the amniotic fluid, goes in your lungs, right? So what paramedics would do, right, when we come in, because you guys cannot do this procedure, what we would do is we would intubate them. Right, so this is called the endotracheal tube. Right? So this tube goes in the trachea, right? And the trachea inside the lungs, right? And then up here we go. Right? This is the Yankar, but we obviously cannot put it. So what we would have done is, right, after we intubate it, we connect this meconium aspirator on it, like this, and the suction like this. And then we would, once it's in the lungs, we would suction the meconium, the first poop, right? And then obviously if we need to do CPR and back up, and once we intubate, we basically connect the BVM through it, right? You probably guys familiar with this, right? Then we ventilate them through this, right? So that was some of the things that paramedics may do, right? So you give them on to nurse. Now you have 2 patients, so you need 2 ACRs, right? And then, come on. So you're gonna need 2 ACRs. Something we wanna talk about is the Apgar score, right? What's the Apgar score? Well, who was Apgar? Somebody in your book with a chart. Who was Apgar? You guys had lectures, right? I'm hoping. Who was Apgar? No clue? Yeah. So there was a lady, her name was Virginia Apgar. She was a neonatal anesthesiologist, and she came up with a score, right? Which is done after, how often we do it?
1 minute after birth and then 5 minutes.
Excellent, right? So at 1 minute and 5 minutes. So does the Apgar score tell us to start CPR or not start CPR? Huh? So do we need the Apgar score to tell us to resuscitate the infant or the neonate, I should say? No, right? Because you're not going to wait 1 minute. If the baby is limp, his cyanotic heart rate is 40. Should I wait the whole minute to start to do CPR and ventilations? No. So Apgar score is not meant to initiate resuscitative efforts, right? You could, did it stop? No. And so the Apgar score, right, is, if you see, right, so the way it broken down, right? So max score you could get is 10. Usually when the baby is born, they're never going to get a 10. You know why? Because they have what? Acrocyanosis, right? So in collar, they're only going to get 1, right? Then heart rate, right? Let's say if I don't have a pulse ox, how else can I obtain the infant's heart rate? Let's say I don't have a pulse ox. Let's say you don't really feel the brachial. The baby's moving.
Umbilical cord?
The umbilical cord, excellent, right? You can palpate the umbilical cord for pulsations, and one more, even better.
The femoral?
The what? The femoral. You're not going to feel the femoral. You take your stethoscope, you put midclavicular line by the heart, right? And then you listen for the lub-dub, the heartbeat. You're going to be very fast, like lub, 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 right? And you're going to look at your watch for a minute, right? Or you could do 15 seconds times 4, right? So we said, right, greater than 100 is good. It's 2 points, right? Reflex, irritability. I told you I want them to cry. I want to see them, right, being vigorous and crying. So this is what we want to see, right? If they have no response, they get a 0. If they have grimace, they make a face, they get a 1. Muscle tone, limp, no movement at all, 0. Some flexion, a little bit of movement, they get a 1. And if they're actively moving, right, and as you're drying them, very good, right? They get a 2. Respirations, right? Absent, very bad, they have a weak cry, right? Or they're not really breathing, or they have meconium aspiration, right? Or they have a good cry, strong cry, right? They're crying, they're moving. Whenever the baby's crying, moving, and yelling and doing all kinds of stuff, I love it, right? Because I know the baby's doing good. It's getting pink, right? All that is fine. Give it to the mom to nurse, right? All right. So this is the Apgar score. We said we do it at 1 minute mark, and then again at what minute mark? 5 minute, right? So maybe it's declining, maybe it's improving. That's why we gotta check, right? You're definitely gonna record on your ACR, right? By the way, what would be the when you record, right? So when the baby comes out, the time of delivery is the birth time. So the birth date is today, right? And the time of the delivery that you're gonna note. You're gonna write both Apgar scores, right, for it. Do we need to obtain the blood pressure for the baby? For the infant? No, you probably don't even carry the cuffs the right size. But definitely put a pulse ox, right? We talked about the numbers. You're going to get a heart rate with the stethoscope or the pulse ox or the umbilical cord, which is excellent, right? That you know. You're going to do the pediatric assessment triangle. You're going to assess the baby, right? If we talked about heart rate is less than 100, we do positive pressure ventilation. Less than 60, you're going to do what? Compressions. Hopefully, we don't need to do that, right? Definitely keep the temperature hot. The first thing you always want to do is start with making sure the temperature is up, baby is dry, and stimulate the soles and the lower back, right? You basically rub them and stimulate them, right? Give it to the mom to nurse. Wait for the placenta to deliver 30 minutes. Put it in the bag, label it, right? Call notification to the hospital. Say, we're bringing you X-year-old female, right? With all this. The other thing, I don't know if Moon talked about it, there's something known, which you could ask right in your history, I didn't write it down, but it's something known as GPAL. Right, so we usually say, let's say at 20 28-year-old female presents with G-PAL, right? So G stands for gravida, how many times she had a gravid uterus, right? Peri, how many times she delivered. A is abortions, right? And L is live births, how many children she has. So you could say how many times you've been pregnant, right? If she's having, current gravid uterus, how many deliveries you had, how many abortions, and how many children you have. So those you could say, right? We have a 20-year-old female who presents with complaints of contractions and possible urge to push, imminent delivery. She is, let's say, gravida 2, right? Parity 1, live birth. She has no abortions and 1 child, right? So that would be your history of her obstetric history, right? And then you could ask all your questions, right? Get a setup and all that. So this was your regular delivery, right? So we start with patient assessment and all that. Do you have any questions? Any questions about anything? No? You get it clear?
I have-
Yes? Yeah.
So when you're suctioning the meconium,
Yeah.
and you have to intubate all the way to the lungs,
Yeah.
like past the
Past the
past
what?
the bronchial.
Yeah.
And how does the child breathe?
So at that point, the problem is this, right? Their airway, they're not breathing at all, right? There's that material, that feces and all the meconium fluid is now blocking the lungs, and they cannot even expand, because what expands the lungs is the first breath coming in and expanding, right? And you also have different structures in fetal circulation, right? That basically have shunts, right, between the aorta and the pulmonary circulation that starts to close as oxygen comes in, right? Like ductus arteriosus and stuff like that. So as they try to take a breath in, nothing is going in because the meconium and all that is blocking it, right? So when we would arrive, we would connect it to that specific device, right, to suction them out, right? So that it may not be the first pass. We may have first pass suction, second pass suction, right? And then once it's cleared, then we put another tracheal tube and secure it, right? And then we start bagging it. And how we assess it based on pulse oximeter readings and also the end-tidal CO2 readings, right? That number there, you see like 32, that tells me that they make carbon dioxide. You see that white waveform? The white, like, that looks like boxes, right? So we look at that when we do that, right? Sometimes, truth be told, sometimes we cannot help them with that. And in the hospital, they place them on this machine called ECMO, right? You guys may be familiar during COVID, they place patients on ECMO, right? But that's beyond your things that you need to. For your purposes, if they have that poly-ALS, right, have all your resuscitation equipment ready, your suction unit, your BDM ventilations, right, all that, for your purpose, and poly-ALS.
One more question.
Yeah.
So how long are they not breathing during that intubation period?
So they're not breathing at all. They're not breathing at all.
So until it's over.
Yeah, until we clear them out, because if the airways are blocked, it's like, think of it like this, if you make it very simple. Imagine a person who had vomit, let's say, coming out of the airway. Let's say it's somebody who's doing CPR on them or some other reasons, and that vomit went into the airways. It completely aspirated into the airways, right? So it's blocking the air entry. So unless you clear it, I take a breath in, there's a blockage of air entry. And in the meconium, it could be chunks. It may not be liquid per se. It may be some chunks there too. Right? So until you clear it, you're not going to get an airway. But usually, those moms, they know that, if the complications will arise or something's going on, they may be, they would tell them to seek delivery in the hospital setting. But sometimes it may happen in the field. And the other thing, very obvious, how else you know, so where's my BM? How else you know you have possible meconium aspiration? So first you see like brown tinged meconium fluid where the water broke, and then when you try to bag them, you have high resistance, it's not letting you. So that tells me something is blocking the air entry, right? Make sense? So I see this manometer, right, it's giving me high pressure. Poly-ALS, right, hopefully they're on the way. Any other questions? No other questions? Everything clear? All right, you go.